And for folks in the room and folks online, I think we'll just wait a couple more minutes and see if some more people join us before we start the session. All right. Hello, everyone in the room and online. Thank you for joining with us after lunch. We're hoping that this is a lively enough session where nobody falls asleep. I'm guessing that there's a lot of sanitation nerds in the room, so we're going to get, I think, some pretty interesting technical discussions. That's what we're hoping for. We are going to start off with a few presentations just to set the stage, to make sure that we're speaking the right language and that we all have some shared questions. But then after we have all of our verbal presentations, we're going to try and break it down a little bit and try and have some audience participation and a group discussion. So I'll explain that a little bit more once we get to that. To start us off, and I'm just going to be introducing each of the speakers. They're all very distinguished. To start us off, we have Dr. David Berendes, who is an epidemiologist and the co-team lead for the Global WASH team in the Waterborne Disease Prevention Branch at CDC. His work focuses on global sanitation and hygiene issues, cholera and typhoid, and wastewater and environmental surveillance, taking a multidisciplinary view to address associated population-level health problems. His main interest is working in projects or evaluations combining microbiology, epidemiology, and spatial analysis to generate practical public health action. And David, I will give the floor over to you. Sorry, it should be one of the...
yes, that one.
All right.
If I hit present, will we get it?
I believe so.
Awesome. Hi, everyone. So as Zach said, I'm David Berendes. Great to meet you all. I have the very short and pleasurable duty of just quickly giving you a brief history, contextual overview of where we are in sanitation before I hand it off to colleagues much smarter and distinguished than I to talk about more of their research and interest and really get into the weeds of sanitation, which I think Zach appropriately deemed with all of us as sanitation nerds. So I'm just going to do a brief contextual background on some of sanitation coverage, catching up to about 3 to 5 years ago, right when my colleagues' studies pick up, and they'll tell you more about that. I do want to make a caveat that for this discussion on area-wide sanitation, we're talking about specifically disease causal pathways, pathogen causal pathways. There are, of course, many health outcomes that are not disease outcomes that are worthy of sanitation, but we're just, for the purposes of this session, we're just going to focus on those pathogen outcomes. So any discussion of sanitation or anything at this conference, frankly, starts with the F diagram in 1958, where sanitation, as shown at the bottom there, acts as the primary barrier against fecal contamination, as well as subsequent downstream pathogen exposures and poor health. Sanitation's role of containing fecal pathogens away from human exposure is well defined from here on out, sort of in the sanitation history. However, concern around whether sanitation should be measured in terms of a household sort of one-to-one impact on an individual or in terms of coverage or community level impacts is seen in the literature as early as the 1980s, if not earlier. Blum and Feacham use a sanitation intervention in a neighborhood as their example of what they call the one-to-one problem, suggesting that individual households receiving sanitation interventions in a single neighborhood cannot be treated as independent of one another. And so this is even better illustrated then further on in 1981 when Shuval et al. Started suggesting a threshold saturation hypothesis for sanitation, that is, that we might not realize any benefits until there's some threshold above which we reach with sanitation and community level coverage. However, this level has been continually problematic, and that is some of our task today. So supporting this threshold theory, just a few recent papers. A 2016 review of sanitation impacts on fecal contamination found really minimal impact of sanitation on various fecal contamination outcomes at the household itself. So again, this one-to-one individual household comparison, like stored water in the house, sentinel objects, things like that, just alone. Observed feces at the community level was impacted by sanitation coverage with greater impacts on observed feces in interventions that started and ended sort of below about the 80% threshold. So going from 30 to 60%, going from 50 to 70%, things in that area. And more recently, Holcomb et al. Did observe a 1-log decrease in soil-based molecular markers for E. coli outside of shared compound latrines in the MapSan study, which of course was a full, comprehensive, transformative change in the intervention area and 100% uptake and compliance of sanitation. One example of a study assessing community-level coverage of an intervention and impacts on fecal contamination in India saw a modest improvement in sanitation coverage, about a 27 percentage point improvement from 10% to 37%. That did not yield differences in fecal contamination markers, including human ones, in household or community water sources. However, there are various observation studies, including 2 I'm showing from work we did a little while back, suggesting that at the neighborhood level, sanitation coverage is associated with a level of fecal contamination in drains in urban areas. The first study, neighborhood level fecal contamination in open drains, was high overall, more than 4 log CFU per 100 ml, but varied by neighborhood coverage of sanitation with significantly higher open drain contamination in the neighborhood with less than 50% sanitation coverage compared to the neighborhood that had almost 100% coverage. In the second study, concentrations of E. coli in drains with low coverage areas, that is areas with sort of less than 10%, within about 50 to 100 meters. So thinking now about that radius, how much we care about, how far away from an individual location do we care about the coverage of sanitation. Those low coverage areas for 50 to 100 meters had higher contamination with E. coli compared with other areas. And so we'll hear a little more about some further evaluation of sanitation coverage and fecal contamination in our next speakers, but I'm going to go also to just a little brief overview of some of the outcomes on disease outcomes specifically. So an excellent example of community-wide transformative sanitation intervention with health impacts is in the Bahia Azul or Blue Bay project in Salvador, Brazil from 1997 to 2003. Because the goal was to decrease discharge of domestic wastewater and marine pollution, actually, the intervention was not only multi-neighborhood in scale, but intervened upon multiple elements of the sanitation chain. And so sewer and septic tank connections per household increased from 56 to 88%, and critically, those neighborhoods were those impacts were observed in neighborhood level metrics as well. Households with no open sewage within 30 meters of the house increased from 57% up to 79%, and those with connected sewerage increased around the household as well. And subsequently, diarrheal rates decreased by 22% from before the intervention to afterwards. And the same study also observed impacts on soil-transmitted helminths. So ascaris decreased from 24% to 12%, trichuris from 18% to 5%, giardia from 14% to 5%. And then let's fast forward about 15 years or so. A study from Joe Eisenberg's group in 2016, James Fuller et al. Also provided a nice example of sanitation coverage and health outcomes. In this case, moderate to severe stunting. And so they conducted longitudinal assessments of height in rural villages in Ecuador with varying levels of sanitation coverage, as shown in the figure, which they measured as improved sanitation within 500 meters of the household in question. Then they plotted stunting, with this sanitation coverage indicator and saw that households with 100% coverage of improved sanitation within 500 meters had about 2/3 lower prevalence of stunting compared with those with zero coverage. And they also may have seen potentially a threshold around 30 to 40%, but they had a lot of variability in the numbers of households distributed along that sanitation spectrum. So just to sum up, to kind of catch up to where we are now, if we need to think about sanitation as not just a household good, but also a community level good and account for those potential impacts on fecal contamination and health outcomes, where do we go from here? If we can't just give everyone's sewers with effective treatment plants and citywide sanitation intervention, we need to think about how to incorporate measures of area-wide sanitation, as we're talking about in this session, into our assessments. How do we do this? Where can we do this? What outcomes are this associated with? Those are the questions that the next speakers will get to, and hopefully, critically, we'll hear from you in the last portion about how is it feasible to do this within all of your day-to-day work. And with that, I'll hand it off to the next speaker.
Thank you so much, David. Thanks for setting the stage. And now on to our next speaker, or speakers. I am so happy to introduce Professor Ayse Ercumen, who is an epidemiologist in North Carolina State University's, NC State's Department of Forestry and Environmental Resources. Her research focuses on potable and recreational water quality, the spread of diarrhea, and soil-transmitted infections in low-income regions, health impact assessments for wash projects, waterborne infections, and pathogen transmission risk through piped systems. She is also going to be joined by Professor Joseph N.S. Eisenberg, who is a professor of epidemiology and global public health at the University of Michigan. He studies infectious disease epidemiology with a focus on waterborne and vector-borne diseases. His broad research interests include global and domestic integration of theoretical work in developing disease transmission models and empirical work in designing and conducting epidemiology studies. So I invite, I think Ayse, you're coming up first. All right. Which one is it?
This one.
This one.
There.
All right, and then let's do this.
Thank you. Thank you,
All
Zach.
right.
Zach is one of the few people that can say my name right, so thank you for that. So I'm going to present some empirical data on effects of area-wide sanitation on fecal contamination and child health in rural Bangladesh. And then Joe is going to take it further from there, right? When there's data, there's cool things we can do with it. He's an expert modeler, so he's gonna take us into the modeling space. So when we were embarking on this work, really what we were grappling with, one of the major things is how do we even begin to parameterize area-wide sanitation? What is the right metric to measure? Is there a right metric to measure, right? So we really went broad, and we wanted to kind of capture a variety of definitions to see, does the definition matter in the first place? Right, so what is the relevant metric to capture? Are we just counting kind of the number of folks who have like any latrine at all? Or should we be counting up the number of people who have an improved latrine, or even better, a safely managed latrine, right? So like these were things that we're considering as we're getting started on this work. But also, what is the right scale, right? There's two schools of looking at area-wide sanitation. One is you kind of work with these natural boundaries, like naturally existing entities, communities, villages, clusters of villages, or you kind of take like a, just one household-centric approach and define a radius around them and try and figure out within that radius what is the sanitation situation. In the previous literature, that radius has really been quite variable. There are studies kind of focusing anywhere from 20 meters to a kilometer around a given household, and that's what they define as the area for where you look, where you go and count latrines. And also, you might imagine, right, the effects of area-wide sanitation might not be the same for everyone. I mean, presumably, where your neighbors poop matters a lot more when your neighbors are a lot closer to you in a setting of high population density. And a lot of these settings we work in have seasonal patterns, right? If there's flooding, high groundwater tables, certain seasonal effects are going to be a lot more kind of influential, right, in how your neighbor's sanitation determines your own health. So we did a case study in rural Bangladesh to try and kind of disentangle some of all of this. We enrolled 360 compounds in rural Bangladesh, and in each enrolled compound, we measured child diarrhea, but also acute respiratory infections, right, like sort of through there's some similar infectious processes for getting infected in the respiratory tract. So that was really the weather, like whether your neighbor's sanitation situation affects these two health outcomes. But we also went into the how, right? If we do find an effect, what kinds of mechanisms, what kind of pathways is it mediated through? So we went and measured E. coli in stored drinking water on child and caregiver hands and courtyard soil and in food, right? So this was our attempt at getting back at that F diagram, right? So these are sort of like some of the mechanisms through which pathogens travel. So let's go ahead and measure them. So then what we did was we sent our field staff out to walk in every direction for like 100 meters or 300 steps and really nail down every compound within that radius. And they counted the number of people, recorded the number of people that lived in the neighboring compound, so we can sum them up and figure out within that radius how many people are present. But also they counted the number of latrines, and they went and observed every single latrine to see what's the quality, does it really contain feces, what's going on. And we took GPS coordinates so we can do spatial data analysis. Right, so the way we defined sanitation coverage was we worked with two different definitions. We tabulated the percent of neighboring compounds with at least one latrine, right? Like these guys in this compound, there's at least one place to go. And then we also tabulated the percent of neighboring compounds with exclusively hygienic latrines. So not only do they have a latrine, but all the latrines they got in their compound count as hygienic, which we defined as it's an improved latrine where it does not flush into the environment. And then where it flushes to, a septic tank or a pit, we observe that things are well contained, right? Like it's not leaking, it's a well contained, like it's doing its job in terms of isolating the fecal waste. And then even though we sent our guys out for 100 meters, we were also curious, right? We picked that 100-meter range because of prior reviews saying this is sort of the upper range of how far bugs go from one latrine in the subsurface. But we were also curious what happens if you kind of focus on the closer range neighbors. So we tabulated these parameters both within a 50-meter radius and a 100-meter radius to understand, does it matter, right? Like is it your closest neighbor that matters, or the further out ones as well? And then we had data to also look at effect modification by tertiles of population density and by monsoon versus dry season. And then you can see here, this is the distribution at the top. It's the percent of it's the percent of compounds in neighboring compounds that have at least one latrine within 50 meters or 100. And a lot of the compounds in our study fell in that range, right? Like that bar to your right is quite high. For a lot of the folks that we enrolled, all of their neighbors had at least one latrine. And you can see when we kind of focus on hygienic latrines only, it was a lot more of a spread, right? So the far right are the people where all of their neighbors within 100 or 50 meters had exclusively hygienic latrines. So the way we work with these data is we made binary variables out of them, right? Whether you count it as a 100% coverage household, if all of your neighbors, 100% of your neighbors had at least one latrine, or 100% of them had exclusively hygienic latrines, and we compare them to people where that was fewer than 100%. And these are the results. So, and I'm a fast talker, so hopefully like everybody's still on board. So I'm gonna slow down. So, because this is the meat, right? So on the left-hand side, we're looking at E. coli counts, right? So it's log10 transformed E. coli differences, comparing the people with like kind of 100%, right, sort of neighborhood coverage as opposed to fewer than 100%. And we're looking at 5 different sample types. And then on the right-hand side, there's a prevalence ratio, so it's a relative scale. It's a prevalence ratio of diarrheal disease and acute respiratory infections. And then the 2 bars that you see, or like the 2 estimates of the same color, are comparing the 50-meter radius to the 100-meter radius for the same outcome, for the same exposure. Right, so what we can see from here, right, that so a lot of those, like a lot of these like first bars, right, corresponding to the 50-meter are significant, right? We are seeing some reductions, like significant reductions. If your neighbors all have at least one latrine, you are less likely, or you have fewer E. coli in your stored drinking water, fewer E. coli on child hands and on caregiver hands. And we were seeing some borderline like reductions in diarrheal disease and in acute respiratory infections as well. And then if you kind of have the mental space, right, to compare those 2 bars of the same color to each other, right, you can see the effects are similar, but they're somewhat attenuated when we're looking at that 100-meter radius, like indicating, right, that closer radius is really where things matter, right? So from this, like this is any latrine coverage, right? This is like your neighbors having at least one latrine. And kind of our takeaway from this slide was that effects are stronger when we're looking at the closer neighbors. So next I'm going to show what happens, right, when we compare people who are surrounded by exclusively hygienic latrines versus fewer. And we can see, right, across the board, there's actually no effects, right? What we took away from this was that any latrine mattered more than exclusively hygienic latrines. And then when we broke things down by population density, all of these effects were consistently a lot more pronounced, right, in the higher tertiles, like towards your right, in the higher tertiles of population density, kind of confirming our hunch. These things matter more when your neighbors are close by. So I really need to like very speedily pass things on to Joe, but if you want to learn more, my postdoctoral researcher Jessica Contreras published a paper on all of this, and I felt like I had to put out a plug, and I'm just going to pass it on to Joe.
Thank you, Ayse, for setting this all up for me to talk about developing models for how to think about how to measure sanitation risk at this community level. And so Ayse, collected this amazing data, the kinds of data that you really need to think about the effects of this community effect of sanitation. Without data, we can't really talk about, or the appropriate data, we can't talk about this question of whether or not, and to the degree to which community sanitation matters and whether or not there's a threshold effect and such. There's a lot of open questions here. And what I'm going to describe here is just a model that we've started to develop and we haven't used yet to analyze Ayse's data, but the Ayse's data has been invaluable to actually develop the model structure. So the model basically embeds what we think of as biologically plausible and supported by data, much of the data that Ayse just presented. For example, that risks are higher with higher population densities, which we saw. Risks are higher for compounds with lower quality latrines, for compounds that are closer. And that risks are additive with respect to the number of compounds that are within your, within your neighborhood, whatever your neighborhood's defined as. And so what we can do here is and the power of these models is that we can, once we develop them, we can generalize these results into other contexts. So I just want to run through quickly in just a minute how we construct this model. So we see that total We go over here. So we see that the total neighborhood risk is measured by capital R, and it's the sum of all the different risks that you experience with the compounds. We picked this 100-meter radius, which is consistent with the data that Ayse collected, and we can then sum up the risks associated with all the compounds. And the key thing here is we need to choose a specific radius in which to use, and that's an open question. There's both environmental and social processes that mechanistically define what that radius might be, and I think that's a question that we need to grapple with more later. So what goes into this this fecal exposure here? We just break that down as, is the fecal exposure associated with each of the compounds and multiplied by the distance between the households. So if we just think about the first factor here, we see that it's a weighted sum of the probabilities of having open defecation versus unhygienic and hygienic latrines. That's site-specific information that you can collect, but they're each multiplied by the risk associated with each open defecation, risk associated with unhygienic latrine and hygienic latrine. That's data that actually exists in the literature, and multiply that by the number of people living in the household, we get a metric of risk, a neighborhood risk associated with the given compound. And I just end with this, which is a heat map, it's preliminary analysis of both actually the wash benefits data and Ayse's data. A, B, C, D are the compounds that were enrolled in the wash benefit study. The triangles are all the compounds that Ayse collected, which identify all the neighbors that are also impacting the risks associated with those compounds. And using the model that he just described, we have a heat map ranging from high fecal exposure in the red, low in yellow, kind of allowing us to provide this risk map associated with risks with compound A, B, C, D to get some sense of whether or not these individual compounds have improved sanitation. They're experiencing this neighborhood risk on top of that. And so not addressing that neighborhood risk in addition to that household risk, this heat map shows you the implications with respect to that. And I think this could be used, these kinds of risk maps can be very valuable in helping to plan interventions and studies. So with that, I will hand it over to the next speaker.
All right, thanks for that, Joe and Ayse. So next, I'm going to invite up to the podium Professor Joshua Garn, who is an epidemiologist at the University of Nevada, Reno. He has participated in a number of trials, epidemiological studies, systematic reviews that aim to quantify the impacts of water and sanitation interventions, including several studies focusing on issues related to sanitation coverage. And just a moment before I hand it over to Josh, there is a sign-in sheet, so if everyone can sign in, that would be much appreciated. That should be going around. You can look out for that. There you go, Josh. This one, I think.
Thank you. So I'm going to be talking about a case study of trachoma and herd protection. And I've really liked some of the presentations that we've talked about so far. One of the things that I think this presentation will help with that I'm doing right now is in this study I was sort of forced to do some simpler things. And I think a lot of us who do monitoring and evaluation are sometimes forced to choose to work with the data that we have given to us. And so hopefully I can present kind of a different perspective from that which was just presented. So my study was a part of the global trachoma mapping project, and our question was, are there thresholds of community sanitation coverage that confer herd protection against trachoma? And really, I wanted to understand if all of my neighbors have access to sanitation, does that protect me, even if I don't have access to sanitation personally? And being from the Global Trachoma Mapping Project, which is a very large study, we used data from 13 countries that were collected between 2012 and 2016. And we had data from over 354,000 households on 850,000 children and 13,451 clusters. So really a lot of data to work with, but sometimes when you have a lot of data, you don't have the quality of the data that you might if we'd done something like wash benefits study. So they used a cross-sectional cluster sampling method to sample all endemic districts. And our outcome was active trachoma in either eye or both eyes. And we used mixed effects modified Poisson regression models for our analyses. So how to define coverage, that's something Ayse talked about. We defined coverage, we defined the cluster by natural boundaries rather than using a radius approach. And there's a few reasons that we did that, but really the main reason we did that is because we were dealing with the ministries of health from 13 different countries, and it's just very, very difficult from a privacy perspective to get data that are that granular, to get GPS data on every single household. And so we were sort of stuck from a privacy IRB perspective to using the cluster or the primary sampling unit, people might call it, as our unit of analysis for coverage. But I think there's some pros and cons to this. There's using natural boundaries often align with people, sharing things, sharing a watershed, sharing healthcare, sharing socioeconomic status, and potentially transmitting disease. But also, when you implement this intervention, you're often going to implement it at the local government level, which may align very nicely with sort of these natural boundaries. There's simplified sampling. It's simple to identify and recruit participants. There's also some drawbacks. There's heterogeneity, and that heterogeneity, people may not even mix in some of the clusters. They may be so big that there's no possibility of people mixing from one end of the cluster to the other, which is problematic. And also characterizing boundaries. Sometimes it's very natural. There's a state, there's a city, there's a neighborhood that can be used. But other times it's sort of gerrymandering. You're arbitrarily choosing boundaries, and those boundaries may not align with people's mixing patterns. And so, like was presented earlier, one could alternatively use this radius approach. And that's really nice. Having a household center approach, it gives you a granular view that's precise. You're very likely to have people mixing, particularly within 50 meters or 100 meters or something like that. And I would argue it's still pretty simple to collect the data. It's probably more resource intensive to go out to all of the neighbors, but it's still fairly simple to collect the data. There are some complexities, some cons around this radius approach, I think too. Using, first of all, privacy. Privacy is a difficult thing. Sometimes you're able, as the person doing the monitoring and evaluation, able to collect those data pretty easily. But as a researcher, it becomes much more complex for me personally to do the project as soon as I have somebody's exact location of their house. It requires a little bit more technical expertise for the analyses. And there are some times when the radius may not exactly match a mixing pattern. There's a river there or something like that, but I would say that that's not a huge problem most of the time. We also had to figure out what types of sanitation technology we could use, and I think this is a really difficult thing, and I have very mixed opinions on it. We could use open defecation, basic sanitation, improved facility, improved and not shared, any latrine, hygienic latrine. We have all of these options as researchers, particularly if you're doing primary data collection. We weren't doing primary data collection. We were using data that other people had already decided on how they would be collected and what variables would be included. And so we had access to just a couple of variables, improved and not shared, and we used that for our primary analysis, and any latrine versus no latrine, and we used that for a secondary sort of sensitivity analysis. And as we decide what to use, my opinion as an epidemiologist is that some measures might be more relevant to the outcome that you're interested in. So for trachoma, which is what I'm interested in here, the measures should ideally be related to fly breeding sites. Are we reducing fly breeding sites? Is there feces on the ground? If there's, that's really what we're interested in here, is understanding if we're reducing those fly breeding sites. But other diseases that may not be relevant. And so the measure may change from disease to disease. But when I put on my other hat as a systematic review person, it makes it really hard to combine all of these different measures into a single, meta-analysis. And so there might be some benefits to using a more generalizable measure also. We also had to figure out how to aggregate at the cluster level. And for most of you who do monitoring and evaluation, you probably just sum up the people who have a latrine and divide that by the total population at the cluster level to get just a simple mean. But if you're interested in indirect effects or the effects that are just among your neighbors, and you want that to be independent from your own direct effect or the effect that's just for you, having a personal latrine, you might need to just sum up all of the neighbors and leave you out of it. And these two calculations are, one of them is really easy and the other one's just a little bit harder. Not all that hard, but I remember it taking like overnight to run because I had to do, a couple lines of code, and I have this line in my code that says this takes forever to estimate. It's because I had to run it, and if I messed something up the next day or if my computer restarted, I didn't have any work. And it's just not really feasible or even necessary probably for most of the monitoring and evaluation. If you're not actually trying to calculate an indirect effect, you might be able to just do a simple mean in the population. So what do we find? Well, we were looking at both direct effects and indirect effects, and the direct effect is just, do I have a toilet myself, right? And what we found is that having your own personal household sanitation was protective. We had a prevalence ratio of 0.87. For our herd effects, or what is the effect of my neighbors having sanitation, what we did is we calculated, we put each person in sort of a decile of sanitation coverage here. So, 0 to 10% of my neighbors have sanitation, clear up to 90 to 100% of my neighbors have sanitation. And what it looked like for us is it looked like there was a threshold of around 80 to 90% where you start being protected from trachoma if 80 or 90% or 100% of your neighbors have access to sanitation. Doing this kind of analysis requires a ton of data. I said 13 countries and hundreds of thousands of observations. And that's why we were able to sort of have all of these deciles rather than just comparing like the very top decile to the bottom ones. But as we move forward in time, it's going to become more and more difficult to compare data like this because hopefully we're going to have fewer and fewer people hanging out in these lower deciles of coverage. So we have to figure out how to deal with that. Just one more slide. We also did a model breaking it up for people who had their own personal latrine versus those who don't have their own personal latrine. We found sort of the same thing, that it doesn't matter if you're a household with a latrine or if you're a household without a latrine, you're protected. You have this level of herd protection if you have a coverage level of 80%, or if your neighbors are covered at 80% or more. We had some limitations to our study, and I mentioned some of those, but not all of those. One of the questions we wanted to talk about is, are there key threshold values? And it felt like in my study, it showed that there might be herd protection that's conferred at a coverage value of 80 to 100%. That's sort of what the data was showing. We had some limitations, but I remember around the same time another study came out, and they found the same thing. And so I think there's sort of, in replication, we can sort of zoom in on what the correct answers might be on whether or not there's herd protection. And it's probably going to be different for every disease. It makes a lot of sense. And that is all that I have for today. Rick. Thank you.
All right. Thank you so much, Josh. And sorry to have you sit back down, Rick, but thank you so much for joining this panel. It's really an honor to have you join us and bring in the perspective of the WHO on this important topic. Rick Johnston, I think, needs no introduction for most people here, but I will do it anyway. He is a technical officer at the WHO and the longtime co-lead for the WHO UNICEF Joint Monitoring Program for WASH. The JMP is the official UN mechanism to monitor progress towards the SDG targets for drinking water, sanitation, and hygiene. He manages the WHO side of this WHO-UNICEF collaboration and works on thematic issues related to global monitoring, including ways to improve methods of monitoring drinking water quality and safety, as well as the management of non-sewered sanitation systems. All right, and I'll hand it over to you. Sorry, which one is it?
Let's see, it's this one. Yeah. Thanks, everyone. I think the previous presentations set this up really nicely. We've kind of gone from very intensive efforts, georeferencing all kinds of things, very detailed collection, to Josh talking about making use of the data that are available. And I'm definitely more in the camp of simplifying things and what can we do with data that are already in the public domain. I wanted to start by reflecting on about 5 years ago when a team at WHO led by Jennifer Wolf was producing updated estimates of the burden of disease attributable to unsafe water, sanitation, and hygiene. And at that time, while we were building the model, we were including different variables for water, sanitation, and hygiene, including sanitation community coverage with a threshold of 75% of the population using at least basic sanitation. And that's because this kind of 80%, 75% number has been around for a long time without necessarily very strong empirical support, but it was statistically significant for us to include in the burden of disease estimates. So around that analysis, we also produced another paper looking at published epidemiologic studies that had reported reductions in diarrheal disease and tried to map to each of those settings what the overall fecal contamination level was, integrating these different measures of water, sanitation, hygiene into what we called a fecal contamination index, a FECI. And we found this nice curve where if there's less fecal contamination in the environment, that's towards the right on the curve, you see bigger reductions in diarrheal disease. So it's kind of an analogous idea to herd protection, where if there's just a lot of shit around in the environment, and if you can break multiple pathways, you're more likely to see health outcomes. If you break some of the pathways, but there's still big other pathways, you're less likely to see health outcomes. So I think that's consistent, and as part of that exercise, we produced estimates about populations living in communities that had basic sanitation coverage. And the metric that, the way that we calculated this was to use existing household surveys, which are based on clusters. So a cluster survey, Josh was talking about, a cluster or an enumeration area is usually a group of about 100 or maybe 200 households, a census block often. And then a subset of them, maybe 20 or 30 of those households, are randomly selected for the household interview. So you can use the data from those 20 households or 25 households to see, well, what proportion of those households have whatever level of sanitation coverage you're interested in. And Josh mentioned you could look at open defecation, basic sanitation, improved sanitation, anything. But those data sets are freely available and amenable to that kind of analysis. So that 2018 paper also calculated the proportion of population living in areas with different thresholds. This is showing the population living in communities, if you call a cluster a community, with at least 95% basic sanitation coverage. And you can see that apart from the kind of upper middle income countries, most of the population is living in settings where there's nothing like that level of community coverage with basic sanitation. So I wanted to just illustrate the use of these household surveys, and taking Bangladesh as an example, because there's a rich data set there. We have demographic and health surveys, we have mixed surveys. I picked DHS because there's a nice time series here with 6 different surveys over almost 20 years. And this is a cumulative density function here. I'll talk about how those work. I get confused by them. But basically, over time, you see a progression towards a reduction of open defecation. So the curves represent the cumulative proportion living in areas that have at least some level of ODF, of absence of open defecation. And in the extreme case where there's no ODF, the line would go straight up to 100% because everyone lives in a cluster where less than, where no one's practicing open defecation. So I wanted to just zoom into that just to see how the calculations work a little bit. This is the same data just going from 50 to 100%, showing that nice progression over time. If we look at the vertical line, that's the median. 50% of the population in Bangladesh, the median Bangladeshi, lived in a household where less than, well, the median person lived in a household where 94% of households were free from open defecation in the year 2000. Half of the population lived in communities where less than 94% of households were ODF. The other half lived in households, in communities where more than 94% of the households were ODF. That's the group to the right of the line. So that's kind of the median population. You can also look at thresholds of interest. So if we look at the 75% line, in 2000, it was only 22% of the population living in clusters, communities, where less than 3/4 of households were free from open defecation. You can flip that around and say, well, that means that 78% of the population was living in communities where we have this 75% threshold for open defecation free, which might be a threshold of interest for public health outcomes. And it's nice to see that over time, that number went from 78 to 84, all the way up to 99% of the population in 2018 living in communities where there is less than 1/4 of the households practicing open defecation. Bangladesh has shown tremendous progress in eliminating open defecation. Now, you could do the same analysis and say, well, I'm not interested in 75%. I want to know about 95% of the households, because even a few households practicing open defecation could have big impacts. And you see a similar progression where the population has basically doubled from 47% in 2000 to 92% in 2018, living in communities where at most 5% of the population, which means one household in these 20 households that are measured, by the way, practicing open defecation. Okay, so that's interesting, but there's a lot of different metrics you could use here. You could have different thresholds. You could also use different indicators. So for the burden of disease analysis, we worked with basic sanitation, and I'm showing the same data sets for basic sanitation. The 2 earlier sets we couldn't use because basic sanitation is defined as use of an improved sanitation facility that's not shared with other households, and the sharing question wasn't included in the 2000 and 2004 DHSs. So that's why they're shifted to the left. Coverage is higher, but it's not accounting for sharing. But you see this progression from 19% in, 2007 to 25% to around 45% in both 2014 and 2018. That's the population living in communities where here there's a 50% threshold, where just half of the households practice basic sanitation. And what this shows is that there's still a long way to go towards herd protection coverage levels of interest for basic sanitation in Bangladesh, which has shown such tremendous progress on eliminating open defecation. Now, we can't do the same analysis for safely managed sanitation because that requires other bits of information, what happens to fecal sludge when it's removed from pits and things like that. We might be able to do more granular indicators of sanitation in future rounds of household surveys, which are increasingly including questions about containment of septic tanks and pit latrines. But for now, I just wanted to flag that, these data sets are out there. There are hundreds and hundreds of mix and DHS surveys. But one thing to note from this is the color progression isn't perfect. Actually, the purple line should be on the left of the blue line. It looks like things got worse between 2014 and 2018. I don't think that's the case. I think that's just statistical noise. And there's more noise when you're trying to measure something that involves more subjectivity. So here we're talking about, is that toilet improved or not? And that's a more subjective analysis than the open defecation. Do you use any toilet or not? So I think you'll have greater consistency in data sets that use easier metrics like open defecation compared to ones that use more complicated metrics like even basic sanitation and certainly safely managed sanitation, because one data set to another might not be perfectly comparable. In fact, I started this analysis by including mixed surveys, and the mixed surveys just look different from the DHS surveys. They're measuring the same thing, but they're coming up with slightly different numbers. So it's nice to see some continuity and comparability within the different generations of DHS. Okay, I'm just going to close by mentioning that obviously shared sanitation is an issue in Bangladesh. It's definitely an issue in urban settings. And I think we need to be thinking about how quality shared sanitation, especially in urban settings, could fit into our conceptions of herd coverage or community coverage. Certainly, there are high quality. There's the possibility of high-quality shared sanitation services in urban settings. Here's an example of a study that was done by Ayse called QUIS. I was just in India, and they're really pushing high-quality community toilets and public toilets. Community toilets as a short-term measure until everyone can have an individual household toilets, but there will always be a need for public toilets. We're not at home all the time. And I think they're doing a really nice job in India of defining national indicators for what would count as quality shared sanitation. It's part of their ODF plus classification system, and they have a bunch of mandatory and optional parameters, which I'm not going to have time to tell you about. But they include safety, menstrual hygiene, accessibility, privacy, dignity, et cetera. So I think it's a good model to follow. Last, have to plug that we also have a collection for papers. We're asking for papers related to monitoring of sanitation and wastewater. This is a joint effort between the JMP and UN Habitat that monitors wastewater. We're calling for papers by 1st of February in NPJ Clean Water. It's part of the Nature family, and it's got a good impact factor, and it's open source. So please send us manuscripts if they have something to do with monitoring sanitation and wastewater. Thank you.
All right, thank you so much, Rick. And now we're going to transition in, and I hope we can start to have a little bit more of a discussion. So the first thing we need to do is have all of our speakers come up and sit at this lovely panel. While they do that, actually, if I can ask two of you to bring chairs and just put them up here. Is that okay? Ayse and Joe, thank you very much. These two chairs are the hot seats. So we are hoping that as people ask questions, they are also willing to, thank you so much, Joe. And I will make sure they're not behind the podium once we start. Once you ask a question, we invite you to come up to the hot seat. I also want to make sure that people are not intimidated to not ask questions, so it's not mandatory. If you don't want to come up to the hot seat and you want to ask a question, that is okay. But we would like you to come up and become part of this panel because we want everyone to be part of this discussion. The idea here that we had originally, the motivation for this entire session was not that we want to come up with one answer to this question. I think that there's so many different things to consider, as you've seen in all of these wonderful presentations. We need to think about what is most appropriate for the use in particular when it comes to defining boundaries, defining whether or not we're going to use local political or geographic boundaries, whether or not the area that we're using is going to be centered on the household, whether or not we need to consider densities or thresholds. There's so many different things to consider. Obviously, we're going to have different answers for different contexts. What is important is that we are all talking about this topic, that we're all sharing whatever the research literature is showing us, and that we're basing our decisions both on local constraints as well as the best scientific research that is available. So with that, I'm going to, oh, here we go. So I think I'm going to start us off, and then I'm going to open it up for volunteers to the hot seat. So first question. Let's see. So let's do something, I don't know, I think maybe it's a basic question. Obviously, there's not one answer, so let me get your opinion, panel. Should coverage be defined by a fixed area centered on each house, or should it be a cluster approach based on political boundaries? What's your opinion? Based on scientific literature, logistics, etc. Pros and cons. Yes, Rick.
Well, let me start by saying that there is a ton of data out there that's readily available if you use the cluster approach. And I think having lots of data is a big plus, even if there might be technical advantages to use a more meaningful radius approach.
I'm going to throw in an additional variable and say I would really worry or think about urban versus rural when I'm thinking about whether to use. I'd be fine with a political boundary or something on a rural area, but in a dense urban area, those overlaps become a little bit more consequential perhaps, or there's public toilets perhaps, and not everyone has sanitation. So I would be more towards the radius side, taking into account the practical considerations, of course.
Let me throw in one more variable, I guess, right? Like, depends on the ultimate goal. Like, if the ultimate goal is monitoring versus research, like if you really want to understand granular practices, granular kind of patterns in the data, then sometimes looking in real close is a perk, right? But on the monitoring side, like obviously that's just not going to be very feasible. So like really depends on the use case.
I would say from a epidemiology perspective, no measure is perfect, and we're always dealing with compromises. So there really is, to me, I guess the answer is it depends, and it depends, and I guess that's consistent with what Ayse said, that you have to understand the limitations of the metric you're using, but you are often stuck with the data that you have, and you don't always have the luxury of collecting the ideal data. And even if you wanted and defined what was the best data, again, there's costs associated with it. So I think you just need to understand the limitations of those data and when you do your analysis.
I agree. The one thing I would like to hear personally on this, a lot of us are researchers, and I agree with everything that's been said, but some of you have a completely different perspective as people who are actually implementing these programs in the field, and so I would like to hear that perspective too, because I think I agree with everything that's been said.
All right. I see we have our first volunteer.
I was really hoping that others would stand up behind me and ask a question as well. Oh, thank goodness. Okay. Thanks so much for everyone on the panel. I thought these were a really great set of research presentations. I wanted to get your perspective on, we're starting to see some data about how shared sanitation might actually deliver some significant health benefits, whereas I think when we were developing MDGs and SDGs and defining improved sanitation, it was all about private household sanitation. And I wanted to ask your perspective on how we should be counting things like shared sanitation and what level of access we should be categorizing it as. Thanks.
Rick and I were talking about this before we started this meeting, and we both kind of said, shared is kind of hard to deal with as a researcher. Like, it just kind of is. I think one of the things that I've done in the past is looked at things both ways. including shared as just a normal toilet, and then including it, pulling it out, and just looking at shared separately as a third category. I think those can each tell us something different, but I do think it's kind of a hard thing as a researcher to deal with.
And I think shared sanitation can definitely offer health benefits. It depends on what the counterfactual is. I don't think there's any evidence out there that shared sanitation is better for health than private toilet facilities, which is the aspiration and the metric that's used for global monitoring. But better than open defecation? Yeah, for sure. Also, just to note that the shared sanitation is excluded from basic and safely managed services in part because of health outcomes, but also in part because of concerns about dignity and privacy and being able for everyone to be able to safely use toilets in the middle of the night if they need to.
Yeah, so I bring a practitioner perspective to this. Yeah, and so we do a lot of sanitation with rural dispersed, and I guess I want to know thresholds also on density like that, because the geography might be way more important than like the distance between neighbors. But governments only care about the political boundaries, I'll say that. And then I guess another sort of question to you all is, what about like wash in schools? Like for me, like a school toilet's probably like one of the filthiest places that disease transmission is happening. So I mean, gosh, getting to measure thresholds for something like that coverage is got to be really hard to do. So, yeah.
Would you like to join the hot seat? Thank you. Yeah, so I'll let the panel address that question.
Well, we look at pupil to latrine ratio in schools, and a handful of us have done studies related to that. It's not perfect, but you can see, I saw really strong correlations between the number of toilets in a school and how much toilets are used and things like that. And I agree with you. I've been in toilets in facilities in schools where there's no hand washing, and so there's feces smeared on the wall from wiping with hands, and it can be really problematic. It's difficult, and not only they're not at school all day, and so it matters what they do both at school and at home, and that becomes difficult to quantify if they're really covered when we're talking about several different places.
I'd say your question, building on the previous question, was also making me think about urban areas again, and that, perhaps it really gets complicated. Just I need to map all toilets that are available in an area, regardless of its household or public or school or other options, to really assess what that coverage is and the usability and accessibility.
And this question of density and differences between urban and rural areas, I was also thinking that this, crude approach of using the household surveys, those enumeration areas, they're about 100 households each. And that might be a really big area in rural areas, and it might be a really tight area in urban. So now I'm a little bit concerned that metric is not consistent, across different densities.
Yes, I would also say with respect to, I guess this is also getting back to the question about intensive data collecting versus data that's available. I think with more and more remote sensing and those kind of technologies, we can get at some of these measures and look at, identify where schools are, where public latrines are necessary, and also be able to identify where all the households are. So there are ways to streamline the kind of the way in which we collect data that's not the traditional boots on the ground epidemiology.
All right, any other thoughts? Next person up for the hot seat.
I feel like I've made it in my career because I have a comment and a question. I never thought I'd be one of those people. And I was wondering, Rick, can I build off one of your slides, the fecal contamination index? Do you still have that up where you can go back to it?
Ooh, boy. Okay.
Sorry for
I'm not
complexity.
sure which slide.
I was watching you pull it away. I was like, no, dang it, leave it.
All right,
Not
I'm
only
gonna.
a comment, but a request.
Oh, true. I don't think I'm there yet, so this is going a little far.
First, oh, here we go. Okay. Which slide is it? Second?
Towards the beginning. Yeah.
Towards the beginning?
It's,
Okay.
okay. So for my dissertation, Joe and I did a reanalysis of of the wolf studies. And one of the main things that I was looking at was how sewerage changes all of these metrics that were analyzed when you just put everything into a meta-analysis.
Yep.
And so I'm overly familiar with these studies. And something that I noticed was that the two on the bottom right here, Pradhan and Moray, and then Clausen close to it with the K,
Yep.
those are the three sewerage interventions that were part of this data set.
Yep.
The Walker study was one of the only effective latrine interventions, but it was this it was in Honduras, it was a huge national development project. Villages got to pick their own intervention from a menu, and so it wasn't controlled. In the study, they say we're confounded by rural-urban differences. And so I think this is a great point still, and it stands maybe even better. You get really great curves when sewerage is involved. And I just feel like that fits in with what I've been thinking about since yesterday, these great results from Mozambique, that some of what we are confirming is that really good sanitation works like it does here, like it has in London since the 1600s or earlier, in Rome. And I think that's great. But I just think in this, we've really been talking about latrines and what they can do, so I wanted to say that because it sets up the question, what are the open research questions? It's really what can we do with latrines? And then this is really just on my heart, the fact that what our research questions kind of end up being are, what is the minimum required technology to make effects, which is really important. I think it's a great thing to do, but I honestly just really like to reflect on the fact that that's also kind of depressing.
Yeah.
So my question now, to move into something different, is kind of following up on the school thing, but when we were working on the coverage paper, we thought a lot about people moving between villages or just moving about during their day, and the fact that people aren't just staying put in one place, and that accounting for work and just moving around, going to school, travel, et cetera, and food systems, animals, since a common theme of the conference is bringing those in. So the question is, do you think that those data are available and then easy enough to combine into this to have something that's not just sanitation coverage, but sanitation environment or something, which includes coverage and then some more? Thank you.
Thank you. And would you like to join? Yeah, great.
I mean, personally, I think there's a lot of effort in trying to kind of get a handle on what the animals are doing in this environment. I think the metrics are just being developed. There's, again, just like latrine, there's a variety of ways of do you have cows? Or is there cow feces in your courtyard? Or, there's really no one way to measure it that I feel like as a community we have settled on yet. But I think there's a lot of work that's kind of feeding into trying to figure that out, how that then kind of gets implemented into these larger data collection efforts. As far as I'm aware, we're not there yet.
I would say also, I think probably from the social epi side and the groups that have done focus groups or others, there is an effort to understand and data out there probably on what roughly the geographic area of your social interaction is, and that could be approximated to where you might then poop in the day or interact with. That would be relevant from the wash side. I know, ironically, I was thinking as Ayse was presenting the 50 and 100 meters that one of the studies from a geographer from Ghana, I think in the 2000s or 2010s, chose 50 and 100 meters, but it was based on social cohesion and people's interaction, and ended up landing on that. Not to say that's a perfect number, just ironic, coincidental. But I think those social metrics could help with kind of understanding this a little bit.
Yeah, I just want to take off of that, because I do think that the social processes are critically important, and we do have I tend to have a lack of representation of the social sciences in this area, and I think a lot of, at least from the research perspective, I think a lot of ethnography and qualitative work can go a long ways in understanding what is really happening, and then we need to of course, that's very intensive data collection. We need to understand those general principles and figure out how to scale that up. But I think we lack sorely in this area of bringing social science in to understand how people are living their lives and moving around. And I think we do a lot of guessing in our analyses, but I think we just need more of that social science input.
Oh, sorry, Rick.
On the first point about is it community coverage or is it sewerage that's maybe the driver here? It's really difficult to disentangle sewerage coverage, which achieves high community coverage, with an improved on-site sanitation coverage that provides high-quality sanitation to entire communities. And certainly in 2018, when we were working on the FECE, we didn't have those kinds of high-quality studies for non-sewage sanitation. I think we're starting to see them now. I mean, MapSan is showing some really interesting results in a session that's going on right now. Thank you for being here instead. So, I mean, conceptually, we'd like to hold out and say that what's important is to have entire communities covered with technologies that safely manage excreta, whether they're sewered or not. From a EPI point of view, the studies are all about sewer up till now. So maybe that is a research gap that can be filled through high quality community scale sanitation coverages.
Perspective from the implementation side as well. You all are free to answer these questions if you want to also, not to put you on the spot. No, I know, you asked.
All right, should we go on to the next question?
Okay, thanks. Hi, everyone. So I am a bit nervous because I definitely don't come at this from an academic background. But when I looked at this, so I guess my question, first of all, is what thought went into the cluster of households that are on the sides of the radius around? Because from my experience in different countries, often it is the most vulnerable or it is the marginalized households that are on the borders of that radius. And so what does that tell us about, who do we still need to reach and how do we reach them with sanitation? And I'm asking because I guess my first initial thought is, actually, when we're running a program, it's really difficult to get 100% coverage in a community. So we sort of accept that 80% is good enough, but that's okay perhaps from a health perspective. But of course, we know that it's not okay from a dignity and kind of reaching the last mile perspective. So have you done any work on overlaying some of that data with some of that social inclusion data, and does that exist at all? And not that we have to prove that that is important, but yeah, just any thoughts that you have on whether that's important or not, and whether we need to kind of look at that a bit more. Thanks.
Great. Thanks so much for that question. Would you like to join the hot seat? Not required.
Not really.
Okay, no problem. So any thoughts on social inclusion, equity in sanitation?
I was hoping Antoinette would say something about that. I see her standing up right now.
Hot seat.
Anyone from the hot seat? Opinions on social inclusion, inequity in sanitation access?
I guess that's why selecting thresholds are probably really important.
Yeah, I think, is it on?
Okay.
Up there.
Yeah, so we have tried our best to set science-based thresholds for community coverage for everyone forever districts of Water for People. And I mean, I think what we're missing is a really good methodology to validate the equity inclusion side of like that gap. If we're at 95% community coverage with improved sanitation beyond basic, what is that remainder, the marginalized group? Is that majority women and girls? Is that majority like tribal or low-income communities? So yeah, we're doing our best to kind of try to measure that community by community, but doing that globally is really hard, comparably.
I was just going to note that in our, it is on the end of the spectrum of most intensive perhaps, or fairly intensive in terms of mapping and data you have, but another option that we had used in one of our drainage studies that gets at this a little bit was, instead of defining a radius, letting sort of the clusters define themselves as you look at it from like a spatial perspective. So you're not saying this household and how much of a radius, but you're sort of looking across the neighborhood and seeing where that natural cluster comes out. It has observational challenges with it and methodological challenges, but it is a way to then perhaps see, okay, if there's heterogeneity, is it evenly dispersed across the neighborhood, or is it clustered in a single location like the bottom of the neighborhood itself, geographic bottom of the neighborhood?
Actually, I have a question for you then, because with the radius, I wasn't clear, are you defining a cluster that is the same for all of the households within a radius, or are you defining kind of household catchment areas that are different for each household? Does that make sense?
Yeah, I think it's the latter, that we're just trying to characterize what the neighborhood risk is for a given compound.
Okay.
And that's what the radius means.
Right.
And not about describing the populations. I mean, I think one answer, I mean, we can learn a lot from like vaccine studies. We've been thinking about thresholds in vaccines forever, because that concept of herd immunity. And I don't think the goal, when you say, and we've heard in COVID also, right, we need to get 70% coverage. It's not but the idea, oh, once we get 70%, we're done with. And there's always the ones that we aren't getting at are often the marginalized people in the community that possibly needs it the most. So I think it's a guide with respect to how much resources you need and strategy, but it shouldn't ever be used as an exclusionary thing of, oh, we'll get the easiest 70% and then forget about the other 30%. So I think that's consistent with how we think about vaccination campaigns.
Thanks for that. Yeah, please.
Yeah, I wanted to say something about this same point. So that's why kindly let me go first. I think we have very much, we need to think about what are people's living practices, yeah? And when we see people living on outskirts of cities, they live much more outside. There's so much of richer households that connect either their toilet directly to the drain, or they have a septic tank that never fills and thereby it's connected to the drain, and they certainly rarely have a septic tank, so that goes to the drain. So I'm wondering whether in urban context the idea of a distance is applicable, or whether you should really think about a hydrological system, and you should think about livelihood patterns. That's, yeah.
Oh, great question.
And my other comment is on the earlier, is that if we're really only looking at 80–90% being herd protection, then let's just do that by cluster, because that's actionable for a local government, for example. I don't see so much added value then, if that's only the superficial measure that we use.
All right, thanks. Would you like to join?
No, sorry.
Okay.
I completely agree on the geographical, and was writing down and thinking the same thing of who lives upstream of you. For one of the studies I didn't show, in Vellore, India, we did map the drains, and that was very intensive to walk them. I think now, as Joe was alluding to, you could probably get that pretty easily with Google Maps, because they all run along the side of the road, and some basic topography would tell you what direction everything's flowing. But we did see that, yes, there were kind of a cluster of low levels of enteric infection from, this was like a subset of the Malad study, in the highly elevated neighborhood or so, and then the lower elevated neighborhood had a high cluster of enteric infection going. So I completely agree that who lives upstream of you is really concerning or important.
Yeah, I think I kind of think about the radius idea as really a crude first step at thinking about this. So, and not the end product. And we really need hydrologists and we need engineers to understand how that water is flowing. So I completely agree.
Yeah. And some of those hydraulics will also change with the seasons, right? So like, well, like when it's the monsoon season, all bets are off, like everybody's downstream of everybody else, right? So definitely.
All right, any additional opinions from the hot seats? All right.
Juan Carlos Sapien from Habitat for Humanity. Very good presentations. Thank you to share to us. I was thinking what type of question I have, who, where, when. So I have two. How is the difference, or how do you approach in peri-urban context? Peri-urban sometimes is in the limbo. Is not apply urban methodologies or rural methodologies, and sometimes, or maybe all the times, programs, government programs and even academic don't have very clarity about peri-urban. This is my first question. And the second, in the urban context, what is the challenge that you have to get data, particularly in the slums? We have risk, we have security, and we have strong leadership that sometimes to get in, we need to pay for safety. Thank you.
Thank you. I think we've talked a little bit about urban versus rural. I think that's come up. I don't know if the panel has anything to add to that. All right, I see that there's a, yeah. Please, please.
We have good conversations on Joe's work in Ecuador with others, Karen Levy and others. Was designed originally around an urban-rural gradient, and I think more thought is going into what that actually means, because often was urban, peri-urban, rural, but now they're reconsidering what is in the middle. I don't know if you've had specific thoughts you want to share.
Yeah, I think that's the idea that, I mean, these definitions of urban, rural, peri-urban are politically defined and don't really reflect risk. And so we are, thinking more and more about, well, what is, instead of talking about urban and rural, there are rural-like areas in urban settings and urban-like characteristics in rural settings. And we're finding that true in analysis of dengue and malaria, and it's certainly true with all infectious diseases and enteric pathogens. So the question is, what are the spatial characteristics that define the risks in these areas and derive risk? And those are going to be different for different disease systems. But that's the direction we're moving toward, and away from this idea of talking about urban and rural, which don't really often don't map on at all into risk because they are these politically defined entities.
Yeah, and rural here versus, like, I'm from Turkey, I'm from downtown Istanbul, right? Urban Istanbul is very different from urban Raleigh, right? I think ultimately it's just a function of population density, and it's a bit of an artificial, right, divide that we kind of put labels on it, but you really got to make sure you get a good handle on population density, like when we're thinking about these things.
Have any of you dealt with data points for like an apartment? And like, I don't know if you have specific ways you've dealt with that. Just thinking that would be one spatial point, but it's different households potentially stacked on top of each other, and the spatial analysis might not deal with that well.
It doesn't, but also they didn't have toilets in every apartment, so it was a question of like mapping the sanitation versus mapping the people and where they are. But yes, it really does not do that well. I mean, in some cases you have a radius of 10 meters, and even that is going to capture 20 households or something.
Yeah, we had this really nice, well-funded project, and we used this geospatial grid approach where we went into Google Maps and counted everybody, and we just excluded all of the big buildings. So, I mean, I haven't done it well.
It's a process.
Yeah, I think there's a lot of challenges with all these things. I did have one somewhat technical question.
Zach, just to get to the informal settlement question.
Yeah. Oh, yeah, sorry, please.
I mean, for me, the first thing that comes to mind, I don't know about others, is just the issues that I think other implementers have with implementation in informal settlements, and the association with legitimacy of those settlements applies to data collection as well for monitoring and for other things, like counting those toilets And saying that they're there and putting them on a map that they're there has political implications.
And I also wanted to mention that maybe in a research setting, it can be challenging to collect data in informal settlements, but maybe, I don't know. But for routine monitoring, for things like household surveys that are implemented by national statistics offices, normally they do include informal settlements in part of the survey design. However, they usually don't include them as a separate stratum, so the results are not tabulated by urban, rural, slum. So you'll never see the slum numbers except in some rare cases, but those populations should be feeding into either the urban or rural estimates. And the NSO is, you know, it's not a political organization. They don't have an agenda, so they often have access to households in settings that might be more difficult, even for a ministry where the household would be expecting some kind of service to come. You know, if they answer questions about water, maybe they'll get something. With the statistics office, it's just, you know, asking some questions.
All right, we do have one question online. It's a little bit technical, so maybe we can find a way to expand on it. The question here is, what is the rationale behind using the radius of 100 meters? But maybe we can talk about what is the rationale of choosing a radius of any given distance.
So in our case, that choice was really driven by a prior meta-analysis that had looked at, you know, if there's a latrine here, and this is a setting where people primarily rely on groundwater, which is the case in Bangladesh, how far from a given latrine can we detect like a virus, a bacterium, and the chemicals like nitrate and things like that. And I think the upper range of that kind of landed somewhere like in the 50 to 75 meters. But I mean, that's going to be fairly variable across hydrogeology, right? So I mean, I think there's like really a range depending on how high the groundwater table is. I mean, our particular case, so it was in the end sort of, right, like this seems to be scientifically meaningful, and also I can't like really tell the field staff, like you gotta walk like 10 kilometers from the household. So it just seemed to be like a, you know, a feel-good number where there's science behind it, and they can walk those 300 steps around every household. So I think we've all kind of converged on, like some data are better than no data, like what is the kind of that we can collect. So in our case, that was the backstory to that choice.
And for the drainage data from Ghana, I mean, that I alluded to before, but that 50 to 100 meters was a geographer and I think an ethnographer or so who'd sort of looked at sort of radii of relevance, and I forget all of the particular social metrics, but 50 and 100 were there, and it happened to be actually a previous study in across, so we used that, which was happenstance, because I don't think you're going to get that kind of data everywhere, but happened to kind of converge on those same numbers.
All right, and I think we're getting to the end of our session. I wanted to take just a moment to thank all of our panel and our members of the hot seats. I think this has been a pretty interesting discussion for anyone who's a sanitation nerd. Thank you to everyone in the audience for coming and having a little chat about all these different considerations. I think what we can safely say is it depends. But also, I think that we have highlighted the importance of taking into consideration area-wide sanitation as opposed to tracking sanitation as an individual household. Whatever format that might be, I think will depend on your resources and your needs and the use of that data in the end. One last plug, watch this space because WashPals is going to put together a community of practice specifically looking at area-wide sanitation metrics and monitoring. It's still TBD largely, but it is something that's in the works. So if anyone's interested, do watch out for that. And thanks everyone. Thanks so much.
Sorry, I ate your time. Sorry, I ate your time. I told them like you gotta give more time to that.